We have also something called curling ulcer. This will happen specifically in burn patients. So the idea is in burn, you have a lot of volume loss because of all the skin that's being lost. When you have a lot of volume loss, what the body will do, try to shunt the blood toward the important structures, such as the brain. So what will happen is reduce blood to the stomach, reduce bicarb buffering, acid will dominate, then you'll develop the ulcer. Another one, also a peculiar name, we call it Cushing ulcer. This will happen if we have increased intracranial pressure or steroids or patients on ventilators. So all the patients in the ICU. The idea is the pathophysiology for increased intracranial pressure is you'll have more vagus stimulation. So the vagus will be overactive, secreting a lot of acetylcholine. Acetylcholine also will promote acid production. I'll show that in the picture in a minute. Another one, we call it stress ulcer. The same pathophysiology in burn. So in shock, sepsis, trauma, all these characteristically will have low perfusion. So low blood flow to the stomach, promoting ulcer formation. Lastly, we have a condition, a cancer called gastrinoma, secreting a lot of gastrin. The syndrome, we call it Zollinger-Ellison syndrome. The idea gastrin will promote acid production, and we are not going to have negative feedback. So in other words, this cancer continuously producing gastrin, gastrin going to the parietal cell, telling to secrete more acid, and more acidic environment is not inhibiting this process. So the characteristically here, you will have a lot of ulcers, but in the distal portion of the duodenum and the duodenum. So most of the time, it's only the first part of the duodenum because this is the area directly after the stomach. But in this syndrome, you will have it in more distal portion of the intestine. This picture, I just want to show you here the acetylcholine stimulating acid production. So that will be in the increased intracranial pressure in Cushing ulcer. Here's the gastrin also stimulating acid production. All of them will be channeled to the last pathway here, the proton pump. And remember, the proton pump inhibitors will inhibit this final one. Final part in this pathway. Okay, so how would the patient present? Someone has peptic ulcer disease, how do you think he would present? Well, by far, most of the patient will not present initially, they are asymptomatic. Now, the problem with these asymptomatic patients, they will present with complication later if they were to present. But 70% of them, of those who have peptic ulcer disease, usually are asymptomatic. The other type of presentation will be epigastric pain. Remember, the ulcer, most common location will be the distal stomach and the proximal duodenum in the epigastrium. So the patient will tell you, I have pain in this area. Now, on boards, when you solve a question, usually this pain has a relationship to food. Now, this is not true in clinical practice. The relationship is very poor. But on the board, they will tell you there is an ulcer that will get better with food, another will get worse with food. So when they tell you it's getting better with food, they are referring to the duodenal ulcers. The idea when you eat food, food will buffer the acidity in the duodenum. That's one. Second, will stimulate secretion of bicarb. Now, when they tell you it's getting worse with food, maybe they are most likely pointing toward the gastric ulcer because food will stimulate acid production inside the stomach, increasing the acidity and potentiating the pain from the ulcer. Also, keep in mind that you can also relate that to the weight changes. So the patient is eating all the time because of duodenal ulcer, they will gain weight. If they are avoiding food, they will lose weight. Another point also for the duodenal ulcer, usually at night the stomach will become empty. There is no food intake, so the patient also may present with pain or wake up because of stomach pain. That maybe will be from 11 p.m. to 2 a.m. After a couple of hours from sleep. Other presentations will be any GI symptoms, so bloating, fullness, etc. So all the big symptoms may be a presentation of peptic ulcer disease. Now let's speak about the complications. So we said a lot of patients will be asymptomatic, but may present with complications. So we need to know about the complications. The first one will be bleeding. So if the ulcer went all the way toward, like penetrate the whole thickness of the wall, they may reach a blood vessel. The two you want to remember are the one in the stomach, so this is the lesser curvature. On the lesser curvature, we have an artery called the left gastric artery. So if we have an ulcer here, penetrate all the way to this artery, the patient may present with the bleeding. Now, bleeding could be a fresh bleeding, hematemesis, could be like vomiting blood, maybe fresh, maybe coffee ground emesis. It could be also a lower GI bleeding, melena. In rare cases, it's very severe, maybe fresh blood from the rectum. That's in case if we have a gastric ulcer. Now, if we have a duodenum ulcer and we damage the posterior side, we will reach an artery called the gastroduodenal artery. So this again may be a source of blood, or could bleed too. Also on the posterior surface, anatomical correlation, we have the pancreas. So if you damage the posterior surface of the duodenum or maybe the distal part of the stomach, you may reach the pancreas, and the acidic material starts digesting pancreas, causing inflammation, pancreatitis. This is rare, but maybe it is a board favorite. The last one, if you have an ulcer in the pylorus. So what's the pylorus? It is the gatekeeper under the stomach, between the stomach and the duodenum. If you have an ulcer here in this location, this will cause inflammation. The pylorus is a narrow channel, so inflammation here and may cause an obstruction. So we'll have gastric outlet obstruction. So food will have difficult time bypassing the pylorus. Food will stuck in the stomach, causing pain, dyspepsia. Patient will tell you, I feel the food is not digested. They will go for hours, pain in the stomach, discomfort, etc. Now, lastly, we spoke about penetration to the posterior surface, but if you have it to the other side anteriorly, it will perforate into the peritoneal cavity. So what we'll have is a perforation. The patient will present with peritoneal signs, rigidity, acute abdomen, pain, etc. And the way to investigate it, you will order an chest X-ray, PA view. So here's the lungs. Here's the mediastinum. You can see here's the diaphragm, and beneath the diaphragm, you are not supposed to see this space. You're supposed to see the liver directly. So this space indicates air, indicating that viscous being perforated, part of the GI, allowing air to escape, and air will float up. So the most superior part will be just below the diaphragm. So we spoke about complications. Now let's go for diagnosis. So for peptic ulcer disease, the way to diagnose it is to go with a scope, an upper GI endoscopy, and visualize it directly. This is the way to diagnose it. Another name for upper GI endoscopy is EGD, esophageal-gastroduodenoscopy, because you are visualizing these three parts. And I'm going to show you here an algorithm for the endoscopy with the treatment. So the patient presented with signs and symptoms of peptic ulcer disease, you will perform an endoscopy, EGD. If the history and the findings are pointing toward NSAID use, painkillers, etc., then you simply stop the NSAID, start PPI. So the general theme, whenever you have peptic ulcer disease, you will start PPI, proton pump inhibitors. They will decrease the acid production, promote healing. Decrease acid production, they will promote healing, making it a better environment for the ulcer to resolve. Again, it's clinical judgment. If you cannot stop the PPI at all, if you can't stop NSAIDs at all for a specific indication, then maybe you can resume it with the PPI. Sometimes stop it for a period, then restart them, etc. But general theme, you want to stop them. Now, if there is, it's not characteristically an NSAID induced ulcer, then you will biopsy this ulcer, and you may have different category for the causes. It's either going to be an infection, H. pylori infection. I will come in a minute how to diagnose H. pylori using a biopsy. So in this case, you will simply treat H. pylori, then confirm eradication. We'll come to that in a minute. It could be a malignancy, so cancer. In this case, what you will do, you will stage the cancer and treat accordingly. either resect the stomach or chemotherapy, etc. If there is any other ulcer, unknown reason, simply just start PPI. Again, for all of them, you will start PPI, but for this, there is no reason to tackle, so it's only going to be PPI. Now, general themes for treatment, you want to tell the patient to stop smoking and alcohol. Now, it's not necessarily that smoking and alcohol caused the ulcer in the first place, but the problem, they will impair healing. So stopping them will, because they are toxins at the end of the day, so stopping them will promote healing. Again, stop NSAIDs if the patient is consuming NSAIDs. Always start proton pump inhibitors. They will reduce the acid production and making the environment better for ulcer healing. And lastly, treat the underlying cause. Okay, now we'll go into H. pylori. Do you have any questions, or are we good so far? Let's see the chat.
I think we are good, Dr. Adnan. You can continue.
Okay. So now let's speak about H. pylori specifically, since it's the most common infection. It's the board favorite. It's very important. High-yield concept. Again, it's an organism that's going to colonize the GI. To colonize the stomach, it has the ability to survive the high acidity. So stay in the.
Dr. Adnan, I have a question. So one of the students is asking if the patient is on an NSAID and he develops an ulcer. So what would you do? Would you stop the NSAIDs only, or would you continue the NSAIDs and get PPIs, or would you start them on COX-2 selective inhibitors?
Now, ideally, you want to stop the NSAIDs and start PPI, and preferably don't restart the NSAIDs. But again, it's a clinical judgment. Sometimes you cannot stop it. For example, stroke patients, MI patients, etc. So we'll just start PPI. If you can stop it and you have to restart it before the healing duration, then you do that. So ideally, you want to stop it and start PPI and don't restart it again. But again, based on clinical judgment situation, you may not be able to stop it. So only you will give PPI. Clear? Okay. So another question. I think this chat. So let's continue for the H. pylori. Again, it's going to colonize the stomach. It has the ability to survive the acidity. It's not going to invade directly, but as we said, it will produce toxins and promote ulcer formation. Now, how the patient would present. So again, same with the peptic ulcer disease. Most of the patients are colonized with the H. pylori, but they are unaware of it. So they are asymptomatic. We don't test for usually unless there's symptoms. So they will go unnoticed. Another presentation could be dyspepsia. So feeling discomfort after eating, feeling the food is not digested properly. And pain, etc. Vague GI symptoms. Another one would be acute or chronic gastritis. So inflammation without disturbance of the epithelial layer. It could be peptic ulcer disease, the one we spoke about. It could be also malignancies. So adenocarcinoma will be one. Another favorite one will be maltoma. So what's maltoma? It is a cancer of the lymphoid tissue. It's characteristically associated with the H. pylori. And not surprisingly, but the treatment for it will be antibiotic. Eradication of H. pylori will resolve the problem. Now, how to diagnose H. pylori? So let's speak about each test, then we'll go into the general theme. The first one will be serology. So what's serology? Once someone is infected with H. pylori, the body will develop antibodies. Antibodies will be present in the serum and they can be detected. What's a good thing about it? It's a simple test, blood test. So you'll draw a test and send it for the lab. It's cheap. The problem with it is once the patient is positive, he or she is positive for life. So if they develop another infection, then you cannot use it again because it's positive regardless of the infection status. The second one, urea breath test. Advantages, it's very good, high sensitivity and specificity, extremely good for detecting H. pylori. Let's speak here about the mechanism. So what you will do, you will ask the patient to drink solution containing urea. Then this solution will go to the stomach. If the organism is not there, then it will go to the rest of the GI, will be reabsorbed and secreted in the urine. If H. pylori is there, then what's it's going to do, it will take this urea and split it into ammonium and carbonic acid. This carbonic acid will go to the lung, and then the CO2 of this carbonic acid will dissociate and the patient will breathe it out. Now, this CO2 is different from the normal CO2, so we can detect it. It's labeled, it's different isotope, different weightage. So if you detected this, indicate that there is an organism that was able to split the urea. So it's positive, indicating that H. pylori is there. Now the disadvantages is it's relatively expensive compared to serology and stool antigen. Lastly, we have stool antigens. So stool antigens is simply the bacteria. If it died or it's going to or shedded, went to the rest of the GI, we can detect directly the antigen. The good thing about it, it's cheap. The bad thing about it, nobody wants to deal with stools. So sometimes they will avoid it. Lastly, the best by far is endoscopy. So you'll go directly to the ulcer and biopsy it. Now, what you can do with biopsy, either you directly test for the activity of the enzyme. So you'll have like small jar and small container. You will put this piece of tissue that you biopsied inside it. If it changed color, indicating that there is a urease activity, this indicates that the organism is there. Another thing is to send it for the pathology lab. They will put it under the microscopy, stain it, and if they are visualizing the bacteria itself using special stains, this also indicates the bacteria is there. Last thing, which the gold standard, but nobody will do it, is to culture the bacteria. So you will biopsy the tissue and culture the bacteria. If it's there, then if it's pylori, it's pylori. But nobody will culture, but it is the gold standard. Now, how would you treat it? Again, two general principles. You want to give antibiotics to eradicate the bacteria, the H. pylori, and you want to suppress the acid to promote the healing of the, if there is ulcer, you want to promote healing, or generally speaking, just to decrease the acid so the symptoms would improve. Now we have something called triple therapy, 3 drugs, 2 antibiotics with a proton pump inhibitor, amoxicillin or metronidazole if the patient cannot take penicillin, clarithromycin with a PPI. Another one we call quadruple therapy. It's either if there is high resistance to one of these or if the patient failed the treatment with the triple therapy. Now, last important concept is after the treatment duration, you want to confirm eradication. So basically, the general principle, you will start, sorry, I didn't speak about diagnosis. So we spoke about the advantage of each, but how would you diagnose the patient? So a patient presents with the signs of symptoms of H. pylori infection. Usually, for the sake of board, usually you start either with urea breath test or stool antigen, unless there's an indication for a scope. After that, if one of them are positive, then you go for the treatment. You treat the patient for a specific duration. Then you ask him to be off PPI for a specific duration. After that, you confirm eradication with one of these tests again. So what you are looking for, usually you will have positive test before treatment and a negative test after the treatment. Now, if there is an indication for an endoscopy, you can go for that. Serology, most of the time, are always the wrong answer. Now, an exception, sometime I'll tell you if this is the first presentation with H. pylori, classic symptoms, signs and symptoms, high prevalence in this area, you can go for something called test and treat. So you test with serology, treat with it, then confirm eradication with the urease breath test or stool antigen. But again, usually they are not the right answer, serology. So why you want to confirm eradication? The general idea, you don't want the infection to go, not to be eradicated because there is the risk of malignancy. I remember from 4th year, the doctor gave us a scenario that suppose you treated someone, you forget to confirm eradication. The bacteria is still there. The patient presented after 5 years with the multoma or adenocarcinoma. then this is a mistake. So maybe they will sue you or something. So always treat, then confirm eradication. Any questions, Omar? Or?
We are good. I don't think there are any questions.
Okay. Now, a couple of points, high-yield points. The PBL case, the patient was 62, and he had microcytic anemia. So this is an indication for colonoscopy because all of them will have gastric colon cancer, and colon cancer is there's unnoticed bleeding. So over a long period of time, developed anemia. Also, any patient above 50, this is also an indication for colonoscopy or other screening method for colon cancer. The second thing, when you go with the upper GI endoscopy, you would biopsy the gastric cancer, the gastric ulcer, because there is a possibility of malignancy. But if the ulcer is present in the duodenum, we never biopsy it because it's never malignant. So that's it.
All right, Adnan?
I'm done.
Yeah. Thank you so much for the presentation. Usually the thing about serology, it is only used in low prevalence countries. For example, in the US, H. pylori is not that common. So if somebody tests to be positive, that means he is acutely exposed to H. pylori rather than in an endemic area like the Middle East, where everyone almost has H. pylori. Yeah, this is the thing about serology. So always in our exams, it's going to be the wrong answer.
Okay, I'll stop sharing.
All right. Any questions for Dr. Adnan now? All right. So Abdullah has a question. All right, Abdullah.
Doctor, can you repeat the gold standard for test for H. pylori infections? And what are the other cases for the other tests? When do we use them?
Okay,
Dr. Adnan?
let me open the presentation again. So the gold standard is to biopsy the ulcer, then to culture it. So if you culture it and it turned out to be H. pylori, then you proved it. Now, again, when you biopsy it, you are not necessarily going for culture. Sometimes either you will put the tissue in a jar, testing for urease activity. So if it's positive, indicating the bacteria is there. Another test is to see it under the microscope. So usually the pathology report, they will tell you we saw organism resembling H. pylori, because the only way to say for sure it's H. pylori is to culture the organism.
Wait, but the most important thing, for the exam, I just have to write, as long as I write biopsy, I'm good, صح?
مفروض انه biopsy is enough. Once you biopsy it,
I think the best thing is to write biopsy with the rapid urease test. You should write the urease. You should write it.
Microscope. But I would suggest, as Omar said, in a safe side, the right rapid urease.
Tamam. Thank you.
Any other questions, guys? Dr. Adnan, you wanted to say something?
Yeah, خلاص, شكرا.
All right, thank you so much. Now we'll shift gears with Dr. Qais. I'm gonna handle the mic to him.
Someone is asking above 60 with anemia. Usually, we suspect in colon cancer and not in gastric cancer. H. pylori can cause gastric cancer, but I'm speaking generally speaking. If someone presented to you with microcytic anemia and they are above 50, then we have to do colonoscopy to rule out gastric cancer. Thank you very much.
Assalamu alaikum. Firstly, I would like to thank Dr. Adnan and Dr. Amr for their efforts in this session. And I want to make a few points clear before I start my presentation. So this is by no means a lecture about IBDs. However, in this session, we're going to be discussing in a PBL way. So what I try to do is that I'm going to focus on things that are not going to be mainly that the lectures are not going to be focusing on. However, it's going to be more interactive, more MCQ oriented, so to speak. So with that being said, the main aims of my presentation is that I want you all to understand that this specific topic, which is inflammatory bowel diseases, is a topic that we're going to come across over and over and over. And by saying that, I mean that over the next year, you're going to take this specific topic in 3 different blocks at least, which are the pediatrics block and surgery block and internal medicine block, which makes you notice how important this topic is and how frequent it is. Okay. Omar, is everything clear or I need to adjust a couple of things?
The front is clear and the question is clear. Now I'm gonna allow them to take the poll. Okay.
Okay.
You wanted to say something before that?
No, but I wanted to make sure that the voice is clear and everything is fine.
The voice is clear and the screen is clear. Okay, I'm gonna start the poll. How much time do you like to give them?
30 seconds.
All right, I'm gonna stop it at 30 seconds. All right, now we are closing. Choose your best guess and we close.
Okay.
Here you have the results, Dr. Qais.
Do they see the results too?
Everyone now can see the results.
Okay, excellent. So we can see that the vast majority have answered with inflammatory bowel disease. And firstly, the main point of me adding this question is as an introduction so that we all know how to differentiate an inflammatory bowel disease as a broad term from other types or other conditions. And as 72% of the students who answered this question have answered it with A, the main points that we have ruled out other choices are due to the following. Firstly, she presented with blood in her stool, so automatically we're gonna rule out, at least for the sake of MCQs, inflammatory bowel disease. And from the other symptoms, adenomyosis and UTI do not go hand in hand with any of the symptoms that are mentioned, except for maybe pelvic pain. However, when we discuss the topic of bloody diarrhea and blood in the stool, we will most likely be talking about inflammatory bowel disease. So we're going to go with the next question.
All right, we have another pool, and also you have 30 seconds. All right, we're gonna stop. And I'm gonna share the results.
Okay, so the majority have answered with large bowel perforation, which is more or less, it's not a bad answer. However, the main concept that I want to discuss or present behind this specific question is firstly the age. She's a 79-year-old lady. As we know that inflammatory bowel diseases and in specific Crohn's disease usually happen earlier than this. However, it can happen at any age. This is one important point that we need to discuss. Another important point is that the patient is seeing fecal leakage in the urinary bag, which means there is fistulation, and usually fistulation comes with Crohn's disease. It presents with fistula. That's why I have chosen this question. So those are the two important concepts that we need to remember from this question, from this MCQ.
Dr. Qais, do we allow questions now? I think we have some questions.
I prefer to leave them until we finish everything.
All right, all right, all right,
okay.
all right. We have a new pool. People are taking more time on this question.
Yeah.
And we have mixed results actually. All right, enough?
Yes.
Okay. I'm gonna share the results. Here you go.
So from this question, one important point that we need to keep an eye on is the goblet cell depletion on rectal biopsy. Whenever you see signs of an inflammatory bowel disease that are associated with goblet cell depletion on rectal biopsy, usually the right answer is going to be ulcerative colitis. Usually Crohn's disease present, usually goblet cells are present with Crohn's disease and not an ulcerative colitis.
Dr. Qais?
Yes.
Can you please, whenever you answer the question, just highlight for them the letter? For example, the answer A is the right one. Yeah.
طب لحظة.
Thank you.
1 minute. So we're going to go back to the very first question, since this is recorded. So in this question, we all agree that it's an inflammatory bowel disease, which is A. In question 2, we said that there is fecal leakage in the urinary bag, which is indicative of a fistula that most likely is caused by Crohn's disease. In this question, which is the question we just answered, goblet cell depletion, which goes hand in hand with ulcerative colitis. Okay. Can we start another poll for this question?
Sure. Here you go.
Okay, enough for this question.
All right, we ended the poll, and I'm going to show you the results.
So excellent. So the right answer here is D. And also we have signs of inflammatory bowel disease in the stem of the question. How do you differentiate between Crohn's disease and ulcerative colitis? In this case, the barium enema is going to show cobblestone mucosa. And when you see cobblestone mucosa, the right answer is Crohn's disease in an MCQ situation or in an MCQ question. However, when you see loss of host relations, also in with barium enema, you go with ulcerative colitis. So the answer here is D. Okay. So after we're done with the MCQs, as you could tell, the main focus or the main aim for me giving this small session is to focus mainly on differentiating between Crohn's disease and ulcerative colitis. So after you know from the question that this is mostly an inflammatory bowel disease, it's usually not going to be as straightforward as this. So what you need to do is to be able to differentiate between the two distinct or two main types of inflammatory bowel diseases, which are Crohn's disease and ulcerative colitis. So, and if this session is going to be recorded, I'm going to leave this for you. An important point here that aphthous ulcers can be present in both, so it's not specific to one of them. And an important point here that you need to know, of course, in exams, usually when you're asking an exam that there is diarrhea and you're suspecting an inflammatory bowel disease, and the diarrhea is a non-bloody diarrhea, you're most likely going to think about Crohn's disease. So, to make it easier to memorize it, you can deal with Crohn as a person, as a human who's called Crohn. And with that being said, so you can say, for example, to make it easier for you to memorize it, that Crohn is clean. So Crohn doesn't have blood, he's clean. And he's always right. So usually when there's a mass that happens on the right side, or that's on the right side in a scenario that involves an IBD patient, you're gonna think also about Crohn's disease. You can also say that Crohn has a goblet. So goblet cells are present in Crohn's disease, and so on and so forth. So once you deal with Crohn, of course, this is as any not any. I'm not going to say it is a very intelligent mnemonic, but it's a way to memorize it, and that's how I personally memorize it. An important thing that Crohn has skip lesions, and it is transmural. Since it is transmural, this is what makes it fistulating and leads to fistula. This is also an important point. Another point, in opposing to the previous question where you said that 1 minute, that you're going to see cobblestone mucosa on barium enema. Here, barium enema is going to show loss of hostrations. And this is also another comparison, or another head-to-head between Crohn's and ulcerative colitis. One important point, who knows, if you can answer in the comments, who knows?
Qais, if you'd like, I can put true or false poll. How about this?
Okay.
All right, I will put a true or false poll, but just asking the question. So, for example, ask them, does Crohn become worse or better? Yeah, you know?
Yeah.
Okay, I'm gonna now initiate a poll, but just 1 second. This is the fourth poll, and I'll start. So now they have a true or false. Just mention a statement, Qais.
All right. So statement number 1, ulcerative colitis improves with smoking.
Start, guys.
Or smoking prevents, or as a preventive factor with an ulcerative colitis. Both go in the same way.
Right. So I'm gonna stop the poll.
All right.
Most
so
of them, yes. Most
And
of
the
them,
answer is
they said true.
Yeah. So usually, smoking is a preventive factor with ulcerative colitis, and that's why usually ex-smokers, when they present with an IBD, it's gonna most likely be an ulcerative colitis. However, it worsens Crohn's disease. So for treatment goals, as we know, most of the diseases that you've studied this year are diseases that cannot be cured. However, are diseases that are gonna be treated for a lifetime. And inflammatory bowel diseases are no exception. And the main goals in such diseases or in such conditions that you need firstly to induce remission. And then once you induce this remission, you need to maintain it. So the mainstay or the main aims in the treatment of the IBDs are inducing remission as an initial step. And once you induce remission, you have to maintain it. And for the induction of remission, I left the medications, the important medications here, and there is no point of me saying them again. So what you need to know is that, of course, it's going to either be a mild to moderate condition. And for such cases, you start with aminosalicylate as a first line medication. However, if it was more severe, in severe cases, you go with oral or IV corticosteroids. After that, after you induce remission, now you want to maintain it. And of course, here we're speaking in the case of ulcerative colitis. There are slight differences between both of them. Once you induce remission in a mild to moderate disease, you also keep going with 5-aminosalicylate, which is mesalamine or mesalazine. However, if it was a severe disease, then you should consider other medications such as azathioprine or mercaptopurine or tumor necrosis factor inhibitors. This is the case for ulcerative colitis. Speaking of Crohn's disease, one important difference is that in the induction of remission, you start with corticosteroids. Unless there was indications or there were indications, you can go with aminosalicylates. And here is also a mnemonic that C is for Crohn's and C is for corticosteroids as a first line to induce remission. Now to maintain it, for Crohn's, you can see that we go directly to azathioprine or mercaptopurine or methotrexate directly. And this, one of the main reasons for this that you go for more aggressive drugs, because usually Crohn's disease is, as we know, it's transmural and it comes in skip lesions, and you need a more aggressive treatment to prevent its complications. Now, this is a picture of a complication to one of the two conditions. Can any of you tell me what do you see on the X-ray and what complication is it for?
So you can write in the chat the answer. Okay. So they are mentioning toxic megacolon in what disease, guys? In ulcerative colitis, they mentioned. Yes. Dr. Qais?
Yes, Mark.
Yeah, they answered toxic megacolon in ulcerative colitis.
Excellent. So there is one last thing we need to discuss, which is the colorectal cancer screening. Both conditions can lead to colorectal cancer. There is no exceptions. Both of them would lead to cancer after a long time. So we need to do screening, and the way we do it is after 8 years from the diagnosis, we start doing it either annually or biannually, depending on how severe it is, of course, and the risk factors of colorectal cancer in this specific patient. And we do it by colonoscopy with biopsy. So one last thing that I need to emphasize on, that this was brief and straight to the point and focusing on on the main points in my own point of view, and how you're gonna be asked about it in the exam when it comes in the exam. Other points such as things that are gonna or that were discussed in the pathology lectures and pharma lectures are things that are already written in the slides. The point that I wanted to make here is that how to tackle it when it comes to you in an MCQ or maybe even an SAQ in the exam.
Dr. Qais, you want to take questions now?
Yes, sure.
First of all, thank you so much for the presentation. So the first question is, do we need to know the details of the treatment for the exam?
Yeah, for this question, of course, if I was the one writing the exam, I would have a clearer answer for this, but unfortunately, it all comes down to what you've taken in the lectures. So if you've studied it in pharma, which is something I'm not sure about, then you just need to know how the main medications for induction and the main medication for maintenance and severe or moderate. I don't think you're gonna have to know more than that in the exam.
Any other questions, guys? Either raise your hand or just write it in the chat. All right, 3, 2, 1. I don't think we have any more questions. Thank you so much.
Thank you.
And let's move to level, right?
All right.
All right. All right. So guys, Assalamu alaikum, welcome everyone. We're going to discuss the last case, which is case 5, which is the liver case. Start with, I'm going to summarize the case. The case is built around a 50-year-old male who has been a cirrhotic for a long period of time, and he presented with the complications of cirrhosis. So we had encephalopathy, we had variceal bleeding in the case. So my main goal in this talk is to highlight the different causes of hepatitis and to highlight the complications of cirrhosis and finally, the general approach to GI bleeding. Okay. Now, as you know, I'm going to try to make it as interactive as I can. I hope if I could like kind of unmute few people and we start discussing, but this is easier when it's a smaller group. So I'll just mention whatever questions I have and you can write in the chat. I'm going to start with the pop quiz on the liver. I'm going to mention to you the scenario and tell me what do you think is the most likely answer, okay? So we have a patient with liver disease and COPD. What do you think is the diagnosis? I don't think the poll will work here. It's just they write the answer. I'm not going to give them choices. Excellent, excellent, excellent. Alpha-1 antitrypsin. What happens is that this antitrypsin, which counteracts the elastase, is produced in the liver. And since it's mutated and misfolded, it will not be able to exit the hepatocytes. So this is when the patients, they have emphysema at a very young age because there's no protection against the elastase in the lung. Also, the liver is getting congested with all of that protein inside it. Next scenario, somebody has liver disease and they have Parkinsonism.
You're writing
Excellent.
Wilson.
Excellent. Wilson's disease. Absolutely. If you see somebody presenting with liver disease and symptoms of neurology like depression or Parkinsonism, recall that in Wilson disease, the copper will deposit inside the hepatocytes and also inside the basal ganglia. This is why it is Wilson. What would you see in the eye of those patients? Kaiser-Fleischer rings. Excellent, excellent, excellent. Now, I'm going to ask you one last question. If they brought a very typical scenario of Wilson's and the ceruloplasmin was normal, does that shake your belief that it's Wilson? Serum ceruloplasmin was normal. Excellent, excellent, excellent. What is the best test for Wilson's? I mean, I don't mean the gold standard, I mean the test that we use in clinical practice. Slit lamp is very good actually, but not all the patients, they have the Kaiser-Fleischer. Excellent, excellent, excellent. For 24 hours, we will collect the copper in the urine. This is the most used test in clinical practice. But of course, the biopsy is the gold standard. It's very invasive and not needed. So we will collect the urine for 24 hours and we will look for copper. Be very careful. You might get an MCQ saying that the patient has all the specific signs and symptoms of Wilson's. He has normal ceruloplasm. Don't worry about that. Just go for Wilson's disease. Next question. There is a patient. I'm going to show you the picture right now. Let me just share my other screen for a second. All right. Just 1 second. I'm going to share it. Yes. All right. So I hope you don't see the answer. All right. Okay, perfect. So here I have a patient. You can see the CT scan and you can see the hand of the patient. He also has diabetes. What do you think is the answer? Hello, can you hear me? Yes, hemochromatosis. Yes, yes, hemochromatosis, bronze diabetes. Hemochromatosis, iron will deposit in the pancreas, in the liver. That's why the liver is lighting up on this image, and it will also deposit in the pancreas, giving diabetes. Be very careful. Yes, this is hemochromatosis. I have a question. A patient with liver disease and presents with testicular atrophy. What do you think is that? liver disease and testicular atrophy. I think we got you on this question. Excellent. Hemochromatosis. But why? Why does hemochromatosis present with testicular atrophy? Yes, in the pituitary. Excellent. In the pituitary. So the iron will deposit in the pituitary and will result in hypogonadotropic hypogonadism. So the testes, which are the gonads, they undergo atrophy because there aren't any gonadotropic hormones from the pituitary. Excellent. All right. Let's go with another question about the liver. You have a patient, he's a muscular athlete, and he presents with intraperitoneal hemorrhage. Young muscular athlete, intraperitoneal hemorrhage. Excellent. It is hepatic adenoma. Why did you answer hepatic adenoma? What did you assume about this muscular guy? Steroids, anabolic steroids. In any exam question, if they mention an athletic male, you would assume that they are on steroids. And if they mention females, you would assume that they are on OCPs. Excellent. You're doing great. Okay, and the complications of hepatic adenoma is that it ruptures and results in bleeding. Now I have a tricky question. Be very careful. Somebody presents with acute ascites and the liver is enlarged and very tender. So painful hepatomegaly and ascites. No. This is a very specific, yes, Budd-Chiari syndrome, Budd-Chiari, excellent. So this is thrombosis of the hepatic veins. And once the hepatic veins are congested, this will result in hepatomegaly actually, and it will be very tender and painful, and also there will be ascites. Remember this. It's not portal vein thrombosis, it is Budd-Chiari, the hepatic vein thrombosis. Because when the hepatic veins are thrombosed, the liver will enlarge because it will be congested. Whereas in portal hypertension, due to cirrhosis, the liver will be shrunken. Does that make sense? Write in the comments. Excellent. You're doing great. All right. So I think we are done with the pop quiz on the liver. Let's go into the discussion. All right. So I'll share with you a white screen and we can start discussion on it. Okay. Let me just put your chat. Let's start with if somebody presents to you with upper GI bleeding. So it can present like hematemesis or melena. What is the most important question that will differentiate the cause of this upper GI bleeding? One question. So as you write the answer, portal hypertension due to cirrhosis, this is what I meant. The liver will be shrunken. The question is, somebody presents with hematemesis. What is the number one question that you want to ask to know what is the cause of this hematemesis? Actually, you want to know if this patient is cirrhotic or not. Because number one cause of hematemesis in cirrhotics is what? Varices. You want to know whether we are dealing with varices or not. And the number one cause of hematemesis in non-cirrhotics is peptic ulcer disease. Excellent. So let's say a patient presents to us and he has hematemesis. The first step is going to be the ABC stabilization. So you're going to make sure that the airway is patent. You're going to provide oxygen for the breathing. But what is the most important step that they will always ask you about in any exams? The most critical step in any GI bleeding? How would you give IV fluids? How? There is a key thing. How would you give IV fluids? Yes, this is the key. 2 IV lines in both arms, and the needle should be big. Actually, it might seem counterintuitive. The smaller the gauge of the needle is, the larger the needle. So a 14 gauge needle is larger than a 22, and is larger than 20, and is larger than 18. Okay? So we'll go for something like 14 or 16 gauge in both arms. Why is that? This patient is losing a lot of blood, and soon the veins will collapse. And if the veins collapse, it's very difficult if one of the lines get kinked or is thrombosed or defective to obtain another line. So from the start, from the kickoff, we'll put 2 lines in both arms and we're going to give IV fluids. Okay? Then, what else do you want to obtain from this IV line? You want to obtain investigations. We'll go for CBC to check for the anemia. What is the level at which we will transfuse? Give me now the level that we transfuse. Actually, now we are more conservative. We look for a target of 7, believe it or not. We look for the target of 7. So you want to look for the CBC to know whether we will transfuse the patient or not. You want to look at the platelets, because in liver disease, the spleen will be enlarged, hypersplenic, it will eat all of the platelets, and also what is produced in the liver. What is produced in the liver that stimulates platelet growth? Platelets. No, I'm really sad. Platelets, coagulation factor, thrombopoietin. Excellent. Thrombopoietin, similar to erythropoietin. Erythropoietin was produced from the kidneys, and thrombopoietin is produced from the liver, and the liver will stimulate platelet growth. So again, we'll check for the platelets, check for the hemoglobin in order to transfuse or not, to give platelets or not, and then we'll check the coagulation factors, because the liver also makes the coagulation factors. Next step, we're gonna also order a very important thing in the investigations. What is that? Think about it. After we obtain CBC and coagulation factors, what would you obtain? Something in the blood. Yeah, coagulation factors is the BT, BTT, yes. What else? Yes, type and cross. Because you will be transfusing this patient, you want to know what is their blood type. So you do type and cross. If you cannot do type and cross, what would you give the patient? If you don't have time and the patient is bleeding a lot? O negative, excellent. So the first step, which was the ABC, was done. So we did the ABCs and we stabilized the patient. Now, in a patient who is cirrhotic, like our patient, he had jaundice, he had all the signs of, he had left upper quadrant pain due to the due to the splenomegaly, and the liver was shrunken. So what medications will you give? This is very important. Now we're discussing the management of esophageal varices. You will give 3 medications. Be very careful. All right. Medication number 1. Be very careful about this point. There is a huge difference between the acute variceal bleeding and the chronic prevention or treatment of varices. Octreotide or somatostatin is used in the acute setting. Why is that? Remember, somatostatin makes everything static. it will shut down all of the hormonal system in the GI tract. So what it will do, it will vasoconstrict the splanchnic vessels. And if the splanchnic vessels supplying the GI are constricted, there will be less blood flow to the portal vein. Less blood flow to the portal vein means less portal hypertension. Okay, so does that make sense? Why we use octreotide? Right for me. All right, so I'll tell you something. I'm gonna consult Qais on this. Qais, would you come on board, please?
هلا عمر.
Yes,
Adnan also is here.
tell me.
Okay, Qais, Adnan, I suggest just we unmute 3 or 4 students. We take some volunteers so they can help me with the discussion.
Fine. يلا.
All right, raise your hand. Raise your hand. Yalla, I'm gonna choose the volunteers. Raise your hands. All right, I'm gonna unmute Derbas. All right, excellent. Derbas, you are unmuted now, and yes,
hello.
and Sinjab also. All right, not a lot. Adnan, okay. We took Sinjab and Derbas. Give me 2 females, yeah, Adnan. All right.
يلا بس let them raise hands أول شيء.
They don't want to? Any volunteers? All right, خلاص. Whoever is there, just okay. I have Derbas and Sinjab and Osama. That's it. Enough. All right. So let's go again. Okay. So as we said, we did the ABCs and then we checked the CBC, the blood cross a match for the patient in order to transfuse. Then the first thing we gave is octreotide in the case of varices. It will inhibit all the hormones of the GI tract, so no vasodilation will be produced, actually vasoconstriction, and not enough blood flow will go through the splanchnic vessels, so decreased flow to the to the portal vein, decreased portal hypertension, and the variceal bleeding will decrease. All right. Amazing. And then after octreotide, we will give PPIs. In any upper GI bleeding, we'll give PPIs. Why is that?
Inhibit the hydrochloric acid, the acidity.
Why? Why?
Decrease it to prevent further bleeding.
Actually, whenever we have upper GI bleeding, a clot will try to form on top of the bleeding, right?
Yes.
Okay.
And the acidity will dissolve the clot. That's why we give PPIs in any upper GI bleeding.
Okay.
Hello.
For octreotide, the hormones, their function is to vasodilate. So if we give somatostatin, it will inhibit the vasodilation. So there will be vasoconstriction, less blood flow, less portal hypertension. Okay? طيب. We gave octreotide and we gave PPIs. What is the third thing you want to give?
Beta blockers.
We will give antibiotics actually, because these patients, they are at very high risk, yes, antibiotics, of getting sepsis or getting spontaneous bacterial peritonitis. Excellent, excellent. All right, and then once we did all of these steps, this is the time to localize the site of bleeding. So we will go with upper GI endoscopy. Where does the upper GI endoscopy reach? What is the maximum limit?
Second part of the duodenum.
First part of.
Yes, the proximal duodenum. And where does colonoscopy reach?
Cecum.
Cecum.
The colon only. Yes, exactly, the cecum. So only the colon. So as you can see, we have most of the small intestine is not covered. Give me 2 ways we can use to image the small intestine.
Camera, pill, and small bowel follow through.
Yes, so we'll do a camera. We will make the patient ingest a capsule. It has a camera inside it. But what is the drawback if we use the camera?
Takes time.
Dr. Omar?
A lot of time
Actually,
and expensive.
Dr. Omar?
Yes, go ahead, Qais.
Yes, but one thing. If there are any questions with chat, would you like me to ask them? Will I keep it
Yes,
till the end?
yes, definitely. Stay with us. So I'm also trying to look at the chat. So when the capsule, the issue with it is that we cannot do any intervention. For example, If we saw an ulcer in the small bowel or an angiodysplasia, we cannot do anything about it because the capsule already have passed, right?
Yes.
But we have a special type of endoscopy. What do we call it? Balloon endoscopy. What is the concept behind balloon endoscopy? Let me draw it for you. The issue with the small bowel is that it is very tortuous. So whenever we try to go with our scope, the scope will hit a dead end and it will stop. Okay? Can you hear me?
Yeah.
Yes.
All right. So we have these balloons, we pass a guide wire, and then this is the scope, it's larger, and then we inflate a balloon. And this balloon will anchor the scope, and then we'll push the scope even more. We will deflate this balloon, push the guide wire again, inflate another balloon. So we are using balloons to negotiate with the bowel. And this actually can go through the whole small intestine. This is what we call balloon endoscopy. So this is how we look for the cause of bleeding. There are two other things that we can use in the case of lower GI bleeding. Give me two other investigations other than the scope.
CT angiography and RBC scan.
All right. So we'll use angiogram. What is the great thing about angiogram is that it will show you the vessels. So if there's a vessel that is bleeding, you can clearly see that vessel that is bleeding, okay? And what we can do about it if we are with the angiogram?
Occlude it, embolize it.
Yes, we can put an embolus that will close this vessel, and that's it. What is the only drawback is that it has to be a large bleeder in order to show on angiography. Let's take the other modality that we have. The other modality is RBC scan.
RBC scan.
Yeah, we just take RBCs and we radiolabel them, we give it to the patient. So this will detect bleeding at the level even of RBCs. So it is very sensitive. But what's the issue with it? It will give you this image. I will draw for you the patient. The image will be something like this. Only it will be a radioactive spot on the scan. So we don't know what is the area, what is the cause. We can do nothing about it. This is the issue with RBC scan. So as we said, RBC scan is very sensitive. It can detect very small bleeding at the level of RBCs, but it does not localize. Angiography, it has to be a larger bleeder, and we can do intervention by which we we can do embolization. All right, I think we covered. And if everything fails and we are not able to control the bleeding, what is the last resort? Guys? Yes, surgery. Yes, any form of surgery. Excellent, excellent, excellent. So we covered now GI bleeding. Any questions about GI bleeding?
No.
All right, excellent. Now I'm going to share with you the hepatitis, a comparison between the different hepatitis. All right. Let's start here. The first thing that we will start with, I'll ask you a question. Let's put them and we will discuss the typical scenarios of each one of them. So here we have hepatitis A. What is the typical scenario of hepatitis A patient? This is a patient who returns from travel and he has jaundice. So post-travel jaundice, this is hepatitis A. Okay, so anybody who returns from travel with jaundice, this is hepatitis A. Let's discuss hepatitis B. What is the typical scenario? This is either through one of the 3 Bs. So either needles, IV drug use, or sexual contact, or through birth. This is what we call vertical transmission. So blood, not blood transfusion, it is the contaminated needles contaminated with blood. 2, baby making, which is the sexual contact. 3, which is the birth. Easy? Remember, hepatitis B, the 3 Bs. Which one is notorious for the blood transfusion? This is hepatitis C. Now, it's very unusual for hepatitis C to come after blood transfusion because we test blood. But the good thing about hepatitis C, it is not transmitted via sexual contact, only via IV drug use or blood transfusion. Any exam question where they bring the scenario of transfusion, the answer is hepatitis C. Let's proceed. We have hepatitis D. The typical scenario of hepatitis D is somebody with hepatitis B and their symptoms become worse. This is hepatitis D. All right. The last one is hepatitis E. What is the typical scenario? This is in expectant women. They expect to give birth. So this is a pregnant lady who drinks contaminated water. Excellent, excellent. And she develops fulminant hepatitis, very aggressive form of hepatitis, and they might even die. Again, hepatitis A, post-travel, hepatitis B, sex and IV drug use, hepatitis C, post-transfusion or IV drug use, hepatitis D worsens hepatitis B, hepatitis E in pregnant ladies. Let's go to the presentation. Hepatitis A, from the name, it will always be acute. Do we have any vaccine for hepatitis A? Write in the comments. Yes, excellent, excellent. We give it for people going to endemic countries. For hepatitis B, it can be actually both. It can present with an acute infection that resolves very quickly, and this is the most common scenario in adults, or it can progress to chronic hepatitis and cirrhosis. Easy? So, do we have any vaccine for hepatitis B? Yes or no? Yes, actually, this is the vaccine that we are given when we are born. And inshallah, when you will go to the hospital next year, they're going to check your titers. And if the immune titers are low, they're going to give you a booster of hepatitis B. Why would they give you a booster? What would they are afraid that you might be exposed to in the hospital? Of course, you will not use IV drugs. Yes, needle sticks, needle sticks. Excellent, excellent, excellent. Good job. Let's go to hepatitis C. Hepatitis C, from the name, it is going to be chronic. It will be always chronic most of the time. Okay, less likely it will be resolving with an acute infection. For hepatitis D, the mnemonic is it is defected. So it has to grow with hepatitis B. And lastly, hepatitis E is just in pregnant ladies, and it's acute. Which ones of them are fecal-oral? The mnemonic is very easy. Remember the word. The word is eat. Okay? So which ones? E and A. Eat. These are the ones that we eat. Are they naked viruses or enveloped? Be very careful. Let me review for you basic microbiology. The envelope actually is derived from the cell membrane or from the nucleus membrane. This has phospholipids. So if this phospholipid goes into the GI tract and is destroyed, that means the virus will die. That's why these viruses that infect the GI tract are always naked viruses. Any virus that infects the GI tract is always a naked virus because the envelope cannot handle the digestive enzymes. Does that make sense? Excellent, excellent, excellent. The last point I want to make, hepatitis B and C and D, all of them can result in chronic infection leading to the complication hepatocellular carcinoma. And lastly, hepatitis B by itself without cirrhosis can result in mutations in the genes and lead by itself to hepatocellular carcinoma. All right, let me share with you another slide. We will discuss the histology right now very quickly. I don't think I have a lot of time, so I'll just focus on the important things. And if you want me to speak about more things, you can tell me. So in hepatitis A, the most important thing are these apoptotic small eosinophilic cells. These are the councilman bodies. They indicate apoptosis, and you can see the cells swelling. This will also indicate apoptosis. This is hepatitis A. Hepatitis B, you can see the ground glass appearance. Do you know the glass that we have in the washrooms? This frosted or like kind of dirty kind of looking glass that you cannot look through. This is the ground glass appearance. This is hepatitis B. And lastly, hepatitis C, very important. You see the lymphoid aggregates. What is the hallmark of cirrhosis? I will draw it for you. It is bridging fibrosis. Remember, here we have the portal triad, here we have the central vein. So there's going to be fibrosis bridging between the portal to portal triads and from the portal to the central. So bridging fibrosis is the hallmark of cirrhosis. Any questions till now? Before I proceed to the serology. Dr. Adnan, please, any questions?
Not a question so far.
Excellent. So I'm not gonna go to the different causes. Sinjab has a question. Go, Sinjab.
What's the finding for Hep C?
Lymphoid aggregations. I'm gonna show it to you. Look here. Here we have the lymphoid aggregations.
Well, it can't be central to central.
Yeah, highly unlikely. It can be anything, but like most typical presentation, portal to portal, portal to central. Don't overcomplicate stuff, guys. This is histology or histopathology.
unmute
Yeah.
تفضل دكتور سنجاب. Wait a minute.
تفضل يا دكتور سنجاب.
Could you please repeat the last point بس.
أي واحدة تبعت what? This one?
Bridging fibrosis.
Yeah, so it is just fibrosis that extends from one portal triad to the other portal triad, or from the portal triad to the central vein. That means that the fibrosis has connected different parts. Okay, like a bridge. That's it. This is the hallmark of cirrhosis.
تمام.
All right. Excellent. طيب. Dr. Qais, I think we should be very quick, صح?
عفوا.
I think we should be quick, صح? يعني just finish in 10 minutes.
As you like, whatever you think is suitable عادي.
All right, I'll finish in 10 minutes. How about this, guys? Any suggestions? 10 minutes is okay? Write in the chat. All right. So now the most important thing that I think everyone wants to hear about, the serology. Let me tell you something. Hepatitis A, it is very easy. We have IgM and IgGs. IgM is just for the acute, IgG for the resolved infection. It's an old infection that got resolved, and that's it. Because we don't have chronic hepatitis A. That's it. IgM means acute infection, IgG means resolved infection. Easy. For hepatitis C, we actually do not depend on the serology. The serology is useless in hepatitis C. It is not sensitive nor specific, does not indicate acute or chronic. We depend on the hepatitis C RNA. We look at the levels, and based on them, we assess the disease, the severity, and the response to treatment. Hepatitis E is similar, IgM for the acute, IgG for the resolved. Which one we depend in hepatitis C on the RNA. Okay, let's go into hepatitis B. To start with, I have to explain to you a very important concept. Here we have the surface antigen. Anything that is part of the virus, we call it antigen. And inside, I have this precious core. Okay, makes sense. This is the core, and outside we have the surface. Now tell me, when we give the vaccine, which do we give the whole virus to the patient? Yes, just only a part of the surface. Okay, this is the vaccine. We give part of the surface. So whenever our body is exposed either to the surface or the core, we form antibodies. So the first antibody is the anti-surface antibody, and the next one is the anti-core. Okay, excellent. So let me tell you something. It is not normal to have the antigen. Having the antigen means that we have the virus. So whenever we see the antigen, that means that the patient is whenever you see the antigen, what does that mean? Yes, infected, has a disease, he has the virus. Does that make sense? The antigen is the virus. So if the patient has the surface antigen, that means he has the virus. If he has the surface antigen, it means he has the virus. So let's look at it here. Here the patient has the surface antigen, it is positive, that means there is the virus. Then we want to know, is it acute or chronic hepatitis B? So what we will do, if it's IgM, it will be answer acute. And if it is IgG, it will be chronic. Excellent, excellent. Okay, let's imagine a situation where the patient does not have the surface antigen. That means he is not infected. We all agree on this. But this patient can be one of four categories. Let's start with the most basic one. This patient does not have the antigen and does not have any antibody. He does not have the surface. He does not have the core. What do you think is this patient? He doesn't have any antibodies formed. He has never been exposed either to the vaccine nor to the virus. He is naive. He has never seen anything in the world. Okay? This is state number one. This is a patient who doesn't have any antibodies against the core and any antibodies against the surface. That means this is a naive patient. All right, let's take another example. A patient who only has antibodies against the surface. What is this patient? Vaccinated. Excellent. He doesn't develop anything against the core because we only gave him the surface, part of the surface. All right, let's take another scenario. A patient has antibodies to both the surface and the core. What is this patient? Previous infection, previous infection. Excellent, excellent, previous infection. Always remember, having the anti-surface, S stands for success. If we form antibodies, the successful antibodies, it means that we have resolved the infection. It either by vaccination or either by immunity after getting infected. The last point. Do you remember that I told you that hepatitis B can be both acute or chronic? Some patients, they only get the acute hepatitis B and they resolve it. So there is a period between having the antigen, this is the antigen, surface antigen of course, and developing the antibodies, surface antibodies. Do you see this period here? This period here, where we were making the antibodies, this is called the window period. The only thing that will show up in this period is the core antibodies, because we are still making the surface antibodies. So this is a period where the surface antigen is disappearing and the surface antibodies are still being formed. So both the surface antigen and the surface antibody are negative. We haven't yet successfully won the battle. We are in the way, but we have the core because the patient was exposed to the virus. Does that make sense? Any questions about the serology? Qais, Adnan?
Why is the core positive, antibody positive?
يعني, what is this question?
يعني already the core يعني جزء من
لا بس I didn't get the question. Either unmute him or let him ask a full question.
طيب I'll unmute عفان الله. دكتور عفان, you can ask, or دكتور عفان. خلي عفان.
Yeah, let عفان.
In the meanwhile, chronic infection will have which antibody?
In what? Yeah, okay, let them just unmute them and let them ask, because this is very confusing.
طيب هنا
Whoever wants to ask, just raise up your hand. We'll take your question.
يا أحسن. Okay, on mute. دكتور سنجاب.
Doctor,
Yes.
explain again the window period. Why?
All right. So let's say that this patient had just an acute infection. He's about to resolve the infection. Okay. So as we said, the antigen, it should disappear when the infection disappears, right?
Yes.
And once the antigen disappears, we will start forming the sign of success, which is the anti-surface, right?
Yeah.
So in this period, we are just forming the anti-surface. So there's a delay between the disappearance of the antigen and the appearance of the successful antibodies. This delay is called the window period.
Okay.
And the only thing that will be positive is the anticore. The anticore will be positive for life. Once the patient is exposed to the virus, he will have anticore for life.
Okay. But if he is vaccinated?
If he's vaccinated, we do not give him the core, right? We only give him part of the surface. So the only thing that he will have is the anti-surface. Do you remember this?
Yes.
Did you see the difference? They are the total opposite. Okay. Any other questions?
طيب في كم واحد رافع ايده او unmute وبعدين ناخذ الاسئله.
Yes. Assalamu alaikum. I have two questions. First one is, in which one of these four situations the antigen E will present? And my second question, in the chronic, if hepatitis B infection went to the chronic phase, which antibodies will present there? يعني هل بده يكون في antibodies or not?
Chronic phase of hepatitis B, right?
Yes.
Yeah, as we said in the beginning, if the patient is infected, you look for the IgGs, anti-core IgGs. That's it. This is chronic.
يعني بس بده يكون في anti hepatitis core.
First of all, the antigen should be there. If the antigen is there, it means this is infection, right? Then we classify the infection either into acute or chronic.
Okay.
All right. For the first question, I did not mention the E antigen, which is the envelope antigen. This is not part of the mature virus. It is just secreted. If it is secreted in large amounts, that means the virus is replicating a lot, and it indicates how much the virus is infectious. So E for infection, infectivity. Okay.
Okay. Thank you.
Any other questions? Yeah, let's go.
طيب في حجازية.
Hi doctor. Yeah.
Hello.
Doctor, I just want to ask you about the window period. Is it like the duration between when we give the antibiotic and the complete clearing of the surface antigens?
أول شيء, yeah. First of all, this is a virus. We don't give antibiotics. We give antivirals.
Sorry.
This is number one. Number two. Usually, the typical scenario is acute infection. So the patient, by his own immunity, will clear up the virus, usually.
Yeah.
So yeah, exactly as you said. So the antigen will start disappearing, and then we will start formulating the antibody to indicate success. So this is the period between the disappearance of the antigen and the appearance of the antibody. Does that answer your question?
Yes, thank you, doctor.
Most welcome. أهلا. Next question.
طيب
I think we'll take last question. Yalla, go ahead.
Doctor, that E antigen, does it indicate a chronic state?
No, only indicates infectivity. The patient can have high or low in both acute or chronic. Only indicates infectivity.
Okay, thank you.
Yeah, most welcome.
قاسم آخر واحد ولا؟
يلا يا قاسم، يلا ما نزعل قاسم. حبيبنا قاسم.
دكتور هلا بس عندي سؤال إنه when we have the window phase, why would we have the core as positive and the surface negative?
As I told you, the minute that the patient is exposed to hepatitis B, they always for life they will have the anticore.
So like the formation of anticore antibodies is faster than formation of the anti-surface antibodies?
We don't form the anti-surface unless we successfully win the battle. Do you remember this?
تمام.
Yes, so whenever the patient will encounter the hepatitis B, immediately they are forming the anticore, and then once they successfully win the battle, they form the anti-surface. Does that make sense?
Yes, thank you, doctor.
Umar Affan is asking the window period why anti-core is positive and anti-surface is negative.
I just answered it.
Okay.
Yeah, next question.
What's the clinical significance of window period?
Clinical significance is that only the core will be positive, because this is the clinical significance. So when you do the tests, you will think that okay, no surface antigen and no surface antibody, there is nothing. Yeah, there was something. So always test for the core.
Okay, someone is asking about the timing of each antibody. Should we know the incubation period for each virus?
I would say low yield. Know it, but I would say very low yield. I wouldn't waste my time on this.
Dr. Amina Rafaid, I'm not sure if this is from previous or another question.
Yalla.
Unmute.
Yalla, unmute.
Sorry, do you have a question? هذا من قبل.
All right. So, all right. I had in mind that we discussed the complications, but I think we will end here and I'll receive your questions. Just one point I wanted to mention for you guys. As we said, in the acute varices, you give octreotide. In the chronic, this is when we give non-selective beta blockers. Why is that? Because beta blockers will prevent the variceal bleeding in the chronic run. It is not acute management, please. This is very important. What happens is it will do two effects. It will affect beta 1, and beta 1 is on the heart. So it will decrease the cardiac output. Less cardiac output, less pressure inside the varices. Number 2, it will inhibit beta 2. Beta 2 will cause vasodilation. If you inhibit this will result in vasoconstriction of the splanchnic vessels, less blood flow to the portal vein, less portal hypertension. This is the mechanism of non-selective beta blockers. Again, beta blockers, chronic prevention. The other one, octreotide in the acute setting. Any questions?
في ناس دكتورة حرون رفعي, she's raising her hand. I'll unmute.
All right, I think I will end the discussion here. I will just take questions.
Okay. دكتور هارون, can you
يلا go.
دكتور هارون.
دكتور هارون.
Dr. Affan is asking, in acute presentation of varices, we give octreotide plus PPI plus antibiotic.
Absolutely.
Harun is asking, can you hear me? I said no.
No, we cannot hear you, Harun. Try again. Did you unmute him? Unmute him. Okay, Harun, just
what to do band ligation, or when to do band ligation?
Absolutely. After you do the PPIs, octreotide, and the antibiotics, you go with a scope to the esophagus and you figure out what you're going to do with the varices. It's beyond your level to know the job of the endoscopist. We have a lot of gadgets in the endoscope. We have sclerotherapy, we have band, we have diathermy. We have a lot of gadgets that are way beyond your level. Harun.
I think
Harun is on. Yeah, speak, Harun. Oh my God. Yeah, Harun, okay. Speak, please. Harun.
I think he has a problem with the mic.
Yeah, he has a problem with the mic. خلاص. just we'll take another question. Yeah, next question.
Two questions.
He will write them. Let's see if the others have any questions. Harun, can you speak? I think I'm hearing I'm hearing your keyboard, I think.
Well, no, he's muted. What's the other virus which has similar tests to Hep A? Or could you repeat why we give PPI in acute varices?
We give PPIs in any upper GI bleeding because there will be a clot trying to form on top of the bleeder, and acidity will dissolve the clot, will destroy the clot. So we give PPIs in order to help the GI form a clot on top of the bleeder, number one. What test? Hepatitis E, also we test for hepatitis E, IgM and IgGs. Yes, of course, if we stop the acidity, this will allow the clot to form. We need a clot on top of the bleeder. All right. Any other questions? Most welcome. Dr. Qais, can you come on board? Yeah, just give them the last words before we end the meeting.
For me, I don't have any last words except I want to thank them for adhering with us, for being interactive. If they need any more sessions, they can directly email us,
Yes.
either email you personally or email the advisory email that we sent the email from. And inshallah, more to come for the coming blocks. Inshallah. Oh, the coming block, one more block that's left.
Okay. Yeah, go ahead. Sorry.
No, I'm done. Yeah. Asfi, I'd like to ask a general question, please. Yes.
Yeah.
Yeah, you can ask.
All right. Yeah, let's take
two informations to share.
Yeah, but
عسكرية يعني.
Yeah, go ahead.
Just remember the malignant feature of the gastric ulcer. Remember one question was about the size. So the larger it is, the more likely it's malignant. Remember, confirming the eradication, the best test will be the upper scope, EGD.
Excellent.
So I think Dr. Shaibani loves this one.
Yeah, he loves that question. All right, let's take Aya first, and then we'll take Haifa. Yeah. Adnan.
في حد عم بيسأل ولا؟
All right. So all right, Adnan, can you unmute Haifa? She wants to ask a question. You can search for. Okay. I'm gonna search for her name. Okay, I'm gonna unmute her now. Okay, so she can ask. Yeah, she can ask now. Haifa? Hello. Hello.
I think she has a problem. Come on, mic. No, we cannot hear you.
No, we cannot hear you. Try again. I think we heard something. Try to speak. Okay, just write it. Yeah. Just write it.
Would you like to take Aya's question first?
Yeah. Okay. When doing gastrectomies, the CCK of the duodenum would not be triggered by the chyme because the chyme will bypass it like in raw. How does the body handle this chyme? You mean how do you secrete bile and pancreatic tissue? Is that what you mean? I just want to make sure that I understood your question. It's like CCK. Yeah, absolutely. One of the complications of gastrectomies, if you recall, is gallstones because of the stasis in the gallbladder. But apparently there are some other hormones that will initiate the secretions, like secretin or others that are not only found in the duodenum, in other parts of the intestine. So it is true, there will be less secretions, but eventually there will be some secretions. Does that answer your question? There is no such a thing as we give the patient CCK. We cannot give the patient CCK. Most welcome. Okay, let's take Haifa's question. In the PBL, there was significance of saying 5 months later. In which part exactly of the case? Yeah. So basically when let me just see the case. I have it here. So in part, I guess in part 1, let me see. I'm gonna share my screen. I'm gonna share the case. Yes. Can you see the case with me right now? So yeah. Part 1, you mean? All right. Second part. All right. The second part. So remember, this patient, he had the blood transfusion like way ago. And the most common presentation for hepatitis C is actually to have a chronic presentation. So he only now presented not with acute or chronic hepatitis. He has chronic hepatitis going for a long time. But now he presented with a complication or a decompensation. He presented with variceal bleeding. This is the presentation. It wasn't related to the hepatic damage because it has been going for a long time, and it's not the acute hepatitis or the acute hepatic insult. Does that answer your question? All right, excellent. Any other questions? Anyone? All right, I'm gonna start the countdown. 5, 4, 3, 2, 1. Thank you so much all. Thank you for attending. It has been really a pleasure to have you all. And Dr. Qais and Adnan, can you stay but just for a while?
Should you end the meeting?
Don't end it. Just start removing the participants with me.